كبر سبحان الله عما يشركون هو الله الخالق البارئ المصور له الأسماء الحسنى يسبح له ما في السماوات والأرض وهو العزيز الحكيم.
कुछ नहीं अच्छी बात इस तरह की शैली इस टाइप की
Welcome you all on the webinar by Punjab Healthcare Commission on supporting data-driven interventions in maternal, neonatal and child health through peer learning and collaboration. First of all, I would like to invite our Chief Executive Officer, Dr. Mohammed Saqib Aziz, for his welcome note on the topic.
Bismillahirrahmanirrahim. I very warmly welcome all the distinguished guests to our speakers. With me, Professor Muhammad Mahmood Shawkasa, who is also our commissioner. I also welcome Professor Muhammad Tayyib, Professor Dr. Rubina Fahir, and Professor Dr. Khwaja Ahmed Irfan Bahir Sahab. I also welcome our VC, Nishtar Medical University, Professor Dr. Mehnaz Afwani, who has joined us on Zoom, and Dr. Harun Hamid Sahab, who has also joined us on Zoom. And I also welcome all the participants and guests who are available and who have joined us on Zoom. Today's topic is, and the purpose and objective of today's topic is to understand from each other, from our own experiences and findings about the importance of data and its usage, and how to use this data when we talk about the evidence-based approach or evidence-based interventions in mother and child health. I would be speaking briefly around 10 minutes on this topic, and will give you an overarching view of the current situation in Pakistan, especially in Punjab also, and the efforts made by the successive governments over the years, and the efforts by the Punjab government this field. And then I will also present a case study and also present some data from our own Punjab Healthcare Commission database. So the building context that why the maternal, neonatal and child health or infant mortality rates and these indicators are important when we talk about any health system in any country. Yes. So these indicators, they are crucial indicators of country's health system and overall development. Basically, these rates, they show the robustness and maturity of health system, and high rates definitely indicates the inequalities or inadequate healthcare infrastructure or lack of access or poor quality. High rates also indicate the socio-economic development, and they are often linked with poverty, low literacy, and limited access. On one hand, these are important indicators when we talk about country's healthcare system. And if we want to reduce these mortality, which some of are preventable deaths, they require basically evidence-based action and not assumptions. We cannot make our policies and intervention on guesses. So we need proper evidence. That's why today's webinar is. So if we try and we
डॉक्टर हाजिर ग्राउंड मैंने कहा डॉक्टर हाजिर शुरू से एक नई स्टोरी शुरू हो जाएगी पहले हम ऑडिट दे रहे हैं बट
उनको म्यूट कर जी
so I mean if we want to reduce the mortality, then we have to improve our systems of performance, and by achieving and by identifying gaps, we can, of course, reduce these indicators. And by achieving this, we can also earn public trust and economic productivity of a country also. Next, please. Now, I will take you to what is happening in the region. On the left side of the slide, you can see the population. And I have tried to make a relative comparison within SAARC countries. So the situation or indicators are not very promising, but still Pakistan is struggling. We can see that in mortality, maternal mortality rate, Pakistan is at 154. On third number, the highest rates are of Afghanistan, followed by Nepal. Then infant mortality rate, again, Pakistan is perhaps on number one position in this infant mortality rate, unfortunately. And neonatal mortality rate, again, our indices are not very good, not encouraging at all. Now, the challenge before us, how to meet the targets and goals of sustainable development goals and targets, which say that by 2030, we have to reduce our MMR indicators up to 70 per 100,000 and NMR to 12 per 1,000 live births, and USMR 25 deaths per 1,000 live births, and IMR infant mortality rates below 20 deaths per 1,000 live births. And we are also signatory of SDGs, and government is now committed to work in that direction and to reduce these indicators from where we are standing today. Next, please. Before we move further, this is the canvas. You can see that what is the factors and challenges before us, starting from the population. I think if you ask me that out of these 9 factors, what is the most important factor, I would say it is, of course, other factors are also very important, but population is something which is not controllable, and we are still struggling to reduce the population control. So it's population, and then the issue of access, inadequate infrastructure, the issues of quackery all over Punjab and our country, then our deficient workforce, unskilled birth attendants, then the issue of referral from tertiary care, from primary and from secondary, and from secondary to tertiary care hospitals, the issues of cultural barriers, illiteracy, awareness. Nutrition is very important. A large number of our women, they die due to anemia, they are anemic. The issue of nutrition, again, needs much importance. And then socio-economic issue, the affordability. So these are basically 9 main issues. But if you see that I have placed 3 other points in the core, which are our policies, which have not been consistent over the years, and the issue of fundings and the credible data for which we have gathered. What is the importance of this data and why we are lagging behind? And when I was preparing this webinar, I tried to get data of initial years of Pakistan from 1947 to 1970s. There's hardly any data available. Then on right side, we have the health facilities in Punjab, and on left side is the workforce. The health facilities in Punjab, we have tried to only project only those facilities which are directly related with mother and child. Although we have data of more than 80,000 HCs, but half of them are non-allopathic. So this is the data of allopathic, which can further be divided between private and public. And from private allopathics is data of only hospitals and GP clinics and MCH, maternity and child homes. We have deleted the data of ophthalmologists or dentists or other single specialties to have a proper picture emerging from this data. And we have then public sector hospitals, 4,821. Some relates to specialized and other are DHQs, dispensaries, and we have more than 2,000 BHUs where these maternal services, whether it is prenatal or natal or postnatal, or they are provided. And left side is the workforce which we have. In the end, if you see the existing MNCH force, which comprises of LHVs, health workers, and nurses, it is only 0.6% on 1,000 population, whereas the target or the average should be 3.6 per 1,000. Next, please. So now I come to some initiatives over the years which the governments have taken. From 1950 to 1979, it is the phase when the infrastructure and establishment of medical nursing and midwifery education was basically done during this phase. From 81 to 90, this is a phase of expansion. We have number of BHUs and RACs and other public sector hospitals, including mother and child health facilities and family planning facilities. During this phase, we have a lot of foreign funded programs, child survival projects with the assistance and support of USAID and UNICEF and WHO. So the first EPI program launched in 1971, and we can say that it was the first data-driven program, and no doubt that program is still going on. It has saved millions of lives of children. So I mean, in our history, we can say that perhaps it was the first data-driven program. In 1990, first national policy came in which importance of data was highlighted and recognized. And then during 1994, the famous program of National Program for Family Planning and Primary Health, the Lady Health Visitors, was launched. It was planned to increase the health force and to reach at the village level by inducting thousands of lady health workers. From 2001 onwards, this is the period between, between these almost 22 or 23 years. First came the devolution plan of President Pervez Musharraf, in which the district governments were formed and health and education a lot among and many other departments were devolved at the district level, and the change of governance model. And then came the 18th Amendment in 2010, in which the the concurrent list was abolished and health was provincialized. During these years, there are mixed results, but overall, during the devolution period and then after 2010, the provinces are now responsible for health service delivery. Then in Punjab, first health sector reform program came from 2007 to 2013, and then the second policy document came in 2013. Third policy and fourth policy documents, they developed in 2012 to 2019, and then the present ensuing health sector strategy was published in 2019, and it covers up to 2028. And basic purpose was to achieve universal health coverage on primary health care, apart from other things also. A very interesting initiative by Punjab government was the introduction of District Health Information System 1 and District Health Information System 2 for data reporting, and later now PITB has also reporting the disease data and other data of health related figures. We can say that there are certain examples in Pakistan which were data driven and were success stories. Like I mentioned earlier, the story of EPI and dengue, and during COVID also, these initiatives were all data driven, and the policies were also made through evidence-based approach. And we can say that a lot of success by approaching and by developing and implementing this strategy. Next, please. Next. So some things, some points that what we are doing as Punjab Healthcare Commission as a regulator, what we have done over the last 20 or 13 years, that we have developed 15 sets of minimum service delivery standards, which cover all hospitals, RSCs, BHC, GP clinics, and midwifery clinics and maternity homes. In all these minimum service delivery standards, our special emphasis has always been on antenatal, prenatal, or postnatal maternal care to the neonates, specialized care to high-risk cases, along with counseling and provision of family planning, immunization, and promoting breastfeeding. Basically, our standards are so developed, and special effort has been made to address all these issues in our standards and indicators. Then we have dedicated set of minimum service delivery standards for maternity homes and MCH centers. And we also published standardized guidelines for performing C-sections. And of course, all these guidelines and standards were made by thorough consultation with all stakeholders. Then during this period, we also trained more than 9,000 staff during our different training programs. We also introduced the self-reporting system of PAS, Performance Assessment System, which is, I would say that a new initiative in Punjab Healthcare Commission, and we encourage the Category 1 hospitals to self-report on different areas, and mortality rates are also one of these areas. We have also introduced IDSR and MPDSR. Basically, the issue and gap which we felt and we experienced is, although public sector hospitals, they are using and they are developing and reporting through the district DHIS 1 and DHIS 2, but the private hospitals, there was no mechanism earlier that where these private hospitals report especially on disease reporting. So IADSR is the integrated disease surveillance and reporting system. We have started this system. We have held a number of meetings with private hospitals that in one. And in coming years, we, inshallah, will be developing. And the ultimate goal is to integrate this data with the data of PITB and data of DHIS2 to have a complete picture of disease and other areas. Now I will show some cases of and some evidence of that what is happening in complaint cases which are received in Punjab Healthcare Commission. Next, please. So the data which I am going to present before you is from 2024 to 2025, and it relates to 1949 cases. So total cases were 1949. Out of these, 611 belong to public sector and 1338 from the private sector. And you can see that out of these cases, 510, a large number of these cases, they relate to gynae. Next, please. So this is a breakup of 510 cases out of these 900 cases. We can see that 24% coming from public sector and 6% were received from private sector. And if we go for urban-rural divide, then again, 70% cases were received. These are basically complaints which we received and adjudicate. And these complaints basically relate to medical negligence, maladministration, and malpractice. And Punjab Healthcare Commission is the only organization where such complaints can be addressed and adjudicated. Next, please. So out of these 510 cases, we can see that 135 complaints were where there were deaths of mother or child, almost 26% of total cases. Next, please. And then again, out of these cases, which basically relate to 135 deaths, 24% were from public hospitals and 82% complaints received from private hospitals. And same correspondingly, same complaints from urban and rural. This data basically present the breakup of these deaths, that what are the main causes and how these deaths occur. So we can see that the PPH is almost 20% of these deaths responsible. Then IUDs 6%, and fetal-maternal deaths, delivery C-section around 8%. Delivery C-section resulted in newborn deaths 18%, and mother deaths during delivery and C-sections, but newborn was alive, so 23%. Next, please. So the main reasons of these deaths, as said, the PPH is on top. Out of these deaths, 32 deaths were because of PPH, and then septicemia, followed by bladder injury or gut injury, resulted in peritonitis. And then the issue of anaphylactic shocks from blood transfusions and eclampsia, preeclampsia, etc. Next, please. So basically, the data which I have told you tells us the gravity of the situation, that how weak our MNCH system is. This data which I am presenting before you is from PAS, our performance assessment system, and we are presenting this data from last year, 6 months data from July to December. And I have mentioned before that the self-reporting, and we have collected data from the number of admissions and on the basis of live births. And on the left side is the maternal mortality reported by 215 category 1 hospitals. And in the legend, you can see that the gray areas are those districts who have not reported because it's self-reporting. And light pink in the dark pink and the maroon color or dark brown color where the maximum deaths were reported. I again would like to reiterate and emphasize that it is not, we are not mentioning here the MMR data. It is not MMR and it should not be interpreted in that sense. Basically, it is based on the, it is calculated on the basis of at least 200 admissions and the live births. And I mean, there is every likelihood that the most of the districts, they did not report. And there's possibility of errors and weak reporting or no reporting. But of course, we have started last year and now we are again analyzing these data. But it is important because first time we have done this exercise in our MNE section led by Dr. Huma. Then middle map, you can see the fetal mortality rate again reported by 206 category 1 HCs. Again, we can see some districts they have not reported and some districts where the figures are higher, like Sargodha and Laya. And again, we are now analyzing the issues. And third one is the neonatal mortality reported by 184 districts in Punjab. And again, you can see different colors that central Punjab, they're more dominant and more deaths are reported. Maybe because of good reporting, that could be one reason. But again, we are now analyzing and of course we will be making policies and we will try to find out the gaps and we will issue our direction to concerned stakeholders for making data-driven and evidence-based policies. So this is basically the purpose of today's seminar also, that the data provides you a proper opportunity to find gaps and you can make your policies accordingly. Next, please. So this data, they basically relate to cesarean section rate and data of 128 category 1 or government hospitals on the left side and data of 129 category 1 hospitals from private sector. And we can see that the data coming from public sector, the number of cesarean section mostly is 51% around, whereas the data coming from private sector, we can say it is mostly more than 70 or 75%. So there's quite change and gap between private sector and public sector. And this data can be further verified and we can second this data by the data of the Sehat Sahulat data, which now I am presenting. Please, next please. So this is a case study of Sehat Sahulat program, which is still ongoing. So now this data I'm presenting before you is from financial year 2022 and 2023. And we can see that in 2022, total deliveries are 102, and out of which 80% were cesarean sections. And 2023, the total number of cesarean sections were 78%, an alarming figure for us. And of course, if we make, we can see that it basically lack proper documentation and and of course, there were monetary incentives and providers' convenience also. But this data also corroborates with our data, which was self-reporting. that the number of cesarean infections the figure was almost the same. Next, please. So what is the goal before us? And we'll start from our journey when the maternal mortality rate was more than 300. Now we are at 2023, we are at the level of 155 or 156 MMR, and we want to achieve the goal of SDGs, which says that by 2030, the figure should further be reduced to 70, and the figure or mortality rate of neonates and infant should also be reduced from 50 to 25 and from 38 to 12. So this goal can only be achieved through strengthening of our MNCH system, which we believe that it is public health security priority, which can only be achieved through evidence-based interventions. I thank you.
Thank you, sir. So our audience had a brief view of what is the issue regarding MNCH and why we should get together and work in a synchronized manner based upon the evidence, design intervention, review the progress, and then design the future interventions. Now I would like to invite the chair of our today's webinar, Professor Dr. Mahmood Shaukat. Professor Dr. Mahmood Shaukat is a renowned pediatrician, a pediatric surgeon, and a pioneer in stem cell therapy in Pakistan. He holds FRCS and has made exceptional contribution to pediatric surgery, both nationally and internationally. Throughout his distinguished career, he has held several prominent academic and leadership roles, including serving as the Vice Chancellor, University of Health Sciences, and Principal, Allama Iqbal Medical College. He was also the first chairman of the Board of Governors, King Edward Medical College and Mayo Hospital. Currently, he is serving as a member of the Board of Management, Allama Iqbal Medical College and Jinnah Hospital. He is also Commissioner, Punjab Healthcare Commission and Chairman, Board of Management, Red Crescent Medical College, and a member of Board of Directors of the Health Foundation. He also serves as a president of the Professional Education Foundation, Lahore. Previously, he was the chairman of the Board of Management at Wazirabad Institute of Cardiology from 2017 to 2021. So we would like Professor Dr. Mahmood Shaukat to please formally begin the webinar.
I was a little confused because I wasn't supposed to give a presentation. And I think that you made my job easier, that we can formally inaugurate the seminar. And I think that's a very good presentation that has set the tone for discussions. And I'm already taking notes. My job today is the easiest of all, concluding remarks.
Yeah.
And so I'm just going to try to find what is important in each speaker's presentation and then try to conclude by picking up what we really need to use for our future references. Thank you very much. Please introduce the first speaker.
Thank you, sir. Next, please. Our first speaker of the webinar from the MNCH experts is Professor Dr. Mehnaz Fakhwani. Professor Dr. Mehnaz Fakhwani is the incumbent Vice Chancellor, Professor and Chairperson of Obstetrics and Gynecology Department, National Medical University, Bhutan. Her expertise in maternal, neonatal, and child health positions her uniquely to provide an evidence-based perspective, especially from South. Her career is marked by outstanding academic achievements, including 22 gold medals and top national honors in medical education, as well as international training in collaboration with University of Liverpool. She has spearheaded educational reforms, served as a facilitator and mentor for international medical trainings, and holds key role in academic quality and curriculum development. As a member of Punjab Public Service Commission and the first female Vice Chancellor of a medical university in Pakistan, her influence extends to mentoring, research, and service delivery, as demonstrated through her leadership of programs such as Kangaroo Weather Care, Thalassemia Prevention, and the Fleming Fund. Her dedication to advancing women's health continues to inspire others in healthcare policy and practice. Dr. Mehnaz will join us online from National Medical Medical College, Medical University.
जी माइक अनम्यूट कीजिएगा।
Volume
अभी कोविड के जमाने में दोनों यूज यानी कि छोटे छोटे ग्लिचेस टेक्निकल पीक कोविड में लोग यूज करते
system. We never buy a new laptop in Pakistan. They are all refurbished. So I mean, you would have all those things. 5 साल 7 साल पुराना लैपटॉप है जब नया खरीदते हैं।
हो गया? अस्सलाम वालेकुम। प्रेजेंटेशन लगा दूँ।
आवाज आ रही है।
स्क्रीन कर दो। Assalamu alaikum. Can you hear me, please?
Ji, loud and clear.
Assalamu alaikum. Thank you very much for giving me the opportunity to be part of this webinar today. And I'll talk about briefly about effect of maternal healthcare utilization and community level factors on maternal mortality especially in South Punjab. So a little brief about the maternal mortality. The maternal mortality is the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration or site of the pregnancy from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. A little bit about maternal mortality ratio and rate. The maternal mortality ratio is the number of maternal deaths per 100,000 live births in a given time period, and it measures the risk of death per pregnancy or per birth, and it is calculated by dividing the total number of maternal deaths divided by number of live births multiplied by 100 and 1,000. And if we see the maternal mortality rate, that is less commonly used, and that is the number of maternal deaths per 100,000 women of reproductive age between 15 and 49 years in a given year. It measures the risk of maternal death in the general population, female population, but not during pregnancy. And the perinatal mortality is that includes all stillbirths, fetal deaths weighing more 1,000 grams or more, or after 28 weeks of gestation, plus all early neonatal deaths occurring within the first 7 days of life. That was the brief introduction about the maternal mortality ratio and rate. And if we see the global perspective, in 2023, over 700 women died every day. So every 2 minutes, a woman was dying from preventable causes related to pregnancy and childbirth. And among these 700 women, over 90% of all the maternal deaths that were occurring in the low socioeconomic group and lower middle income countries in year 2023. And there is a gradual reduction in the maternal mortality ratio between year 2000 and 2023. And that is dropped by about 40% worldwide. But still, ours is very high. We have to work hard to bring it down by year 2023. And the care by the skilled health professionals before, during, and after childbirth can save the life of many women and their newborns. Now, the situation in Pakistan is a little bit different. Pakistan's maternal mortality ratio has decreased from 276 deaths per 100,000 live births in year 2006 to 155 in year 2024. Now, this is still high, and if we compare it from the developed countries, the MMR of USA is 18.6 per 100,000 live births. That of UK is only 13, and that of Germany is 3.9. So we are standing at 155, and the Germany is standing at 3.9. So there's huge differences there. Now, the Sustainable Development Goal 2015 is to reduce the MMR to 70 per 100,000 live births by year 2023. Now we have to achieve this target in next 5 years. So we have to work hard for that. And this webinar is also one of the part of that, that how can we reduce this MMR in the next 5 years to the target level. Now, if we see the causes of maternal deaths, the maternal death could be due to direct causes like pregnancy with abortive outcomes, which include the ectopic pregnancy, the hydatidiform mole, the miscarriage-related complications, then hypertensive disorders of pregnancy, among which the eclampsia is the major killer among the hypertensive disorders. Then obstetric hemorrhage. The obstetric hemorrhage is the leading cause of maternal death overall in our study, which I've done over the last 2 years. And that includes both the early pregnancy hemorrhage as well as the antepartum hemorrhage, both the placenta previa, placental abruption with or without coagulopathy. Then that also includes the cases of morbidly adherent placenta. Then the intrapartum hemorrhage because of the ruptured uterus and before or during the onset of labor. Then the trauma like cervical and vaginal lacerations. Then postpartum hemorrhage is also a major component of obstetric hemorrhage. And then that may be complicated by the coagulation disorders and so on and so forth. The next is the pregnancy-related infections. These infections could be the genitourinary tract infections, could be the puerperal infection, or could be the breast infections. The other obstetrical conditions, other than the above 4 groups, the important being the gestational diabetes, mellitus, the thromboembolism, the central venous thromboembolism, thrombosis in pregnancy and puerperum, postpartum thyroiditis, cardiomyopathy, complicating pregnancy. So this is another group which may be the reason for the maternal deaths. Then there are certain unanticipated complications of management. And these complications are most commonly the anesthesia-related complications that can lead to the maternal death. Then there are certain indirect causes, which are the non-obstetrical complications, including the various other diseases like cardiac disease, including the pre-existing hypertension, not the pregnancy-induced hypertension, then endocrine disorders, gastrointestinal disorders, CNS disorders, respiratory, autoimmune, genitourinary disorders, skeletal diseases, neoplasm, psychiatric disorders, and the infections that are not direct result of pregnancy. The 8th group of is that of maternal death, which is unspecified, and then the 9th group is that of the coincidental causes of maternal death. Now this slide shows the data of the Nishtar Hospital, Multan over the last 2 years. If you can see in the year 1, this is the year 1, and here you can see the maximum deaths were because of obstetric hemorrhage, that was 32 deaths. And in year 2, there were 33 deaths because of the obstetric hemorrhage. So here, the major killer of the mothers is the obstetric hemorrhage in the last 2 years' data. And then the next one is the non-obstetric complications amounting from 10 deaths in the year 1 and 15 deaths in year 2. The third group is that of the hypertensive disorders in pregnancy and childbirth. In year 1, we had 8 maternal deaths, and in the year 2, we lost 10 mothers because of the hypertensive disorders of the pregnancy. And then the next group is that of the pregnancy-related infections, 4 in year 1 and 5 in year 2. So that is the reason, the causes of the maternal death in the last 2 years. If we see the data of the Nishtar Hospital, Multan, which is the major tertiary referral center receiving the patients from the South Punjab, the Central Punjab, and the even areas of the KPK and Balochistan. Now this bar graph shows that the obstetric hemorrhage is the major cause of the maternal deaths. Now this is followed by non-obstetric complications, then the hypertensive disorders, and then the pregnancy-related infections. And the less common reasons. Now this is the pie chart, which is again showing that 54.2% of maternal deaths were occurring because of the obstetric hemorrhage, and again followed by the non-obstetric complications, then the hypertensive disorders and the pregnancy-related infections. This was data of year 2024. And now this graph shows the data of 2025. Again, the same pattern is followed here, that topmost being the obstetric hemorrhage, followed by the non-obstetric complications. The third one is hypertensive disorders, and then the pregnancy-related infections, and then the lesser common causes. Now, again, this pie chart shows that the major chunk is because of the obstetric hemorrhage. Now, this is the age-wise maternal deaths. Here you can see the maximum number of the deaths were occurring in the age group of 30 to 34, in which the most of the ladies, they are becoming pregnant. And the next group is that of the age between 25 to 29 years. The third group is age between 35 and 39 years, and this is the same as that of age between 20 to 24 years. And the teenage pregnancies are less common because overall most of the patients we are receiving in these age groups. Now, maternal death year-wise, you can see in the year 1 there were 60, and year 2 it was 70 maternal deaths. If we calculate the MMR, the total number of pregnancies was 13,500 in 2024. And out of that, we lost 60 mothers. And if we calculate the MMR, that is very high, that is 444. And in the year two, if we calculate the MMR, that is around 530. And this is quite alarming. And that is basically because it is a tertiary referral center and we receive all the complicated patients which are referred here from the various areas. We can just see in the next slide. Here you can see the referral types from the health facility. We are receiving from the various areas like clinics, 25.6% referral, community midwives, 25.6% referrals, DHQs, 25.6% referrals. We are also receiving patients from the THQ, from the RHC, from the BSU. The BSU RHC direct referral is less because these patients are mostly going to the THQ and the DHQ, and then from there, they are referred to the tertiary referral center. From the private hospitals, we are receiving 77% cases. So this is the referral type, and that's why we are having a high mortality because of the complicated patients which are received in the tertiary referral center. Now, this is the month-wise the mortality record, which shows that in year 25, we received maximum number of deaths were occurred in the month of June. And following that in the month of July, where maximum number of deliveries are occurring in these months compared to the other parts of the year. A little bit about MPDSR. In 2013, the WHO launched the Maternal Death Surveillance and Response Guidance. And the idea was to strengthen the notification of the maternal deaths and to review the cause of the maternal death, and then to take the appropriate response to reduce the number of the maternal deaths and to avoid the future deaths. And the continuous cycle of surveillance and response was in that. And in Pakistan, the MPDSR began with local implementation in Punjab in 2015 and in Balochistan in 2017. The national guidelines were developed with the support of WHO in 2018. And in Nishta, we started this program in December 2023. And the key challenges which lead to the high maternal mortality are basically the 3 delays model, that is delay in decision to seek care. Next is delay in reaching the facility. And the third is delay in receiving adequate care at the facility. Now, delay in the decision is basically because of the social and cultural factors, because the decision making is not with the women. And for that matter, we need to empower our women. So we need to educate them and we need to empower them so that they are able to make decision for themselves. Otherwise, some other family member, the husband and the mother-in-law, they are making the decisions. And there's socio-cultural barriers. There is poverty and reliance on traditional birth attendants in the rural areas, which make this decision difficult, that when to shift the patient to the next healthcare facility. Then lack of preconception care. If there is pre-existing disease, that should be controlled before pregnancy, and the patient should enter the pregnancy with that disease well controlled to have optimum outcome during pregnancy. And then once the pregnancy is there, the patients, they're not going for the antenatal care properly. And if the antenatal care is availed, that may not be the quality antenatal care. Then shortage of skilled human resources and essential equipment and the medication, like the theater facilities round the clock, the anesthesia facility round the clock is not available at certain areas. The medications are not available at certain areas. The lack of blood products is the very important factor, because we have seen that obstetric hemorrhage is the leading cause of maternal mortality. And at times the blood products are not available at the setup where the patient is going for the first instance. Then poor referral system may be there, or a lack of the utilization of the proper referral system may be there. The inadequate data and implementation may be there, and unmet need of contraception. So contraception needs should be improved so that the overall the pregnancy rate is reduced and the complication is reduced. And the action plans to reduce the maternal and perinatal mortality. How can we reduce? What can we do? We have to strengthen the emergency care at all healthcare levels. We have to ensure 24/7 availability of EMOG services like cesarean section facilities, anesthesia facility, and the blood banks facility at various levels. And we have to maintain the essential medicine supply, particularly to combat with the atonic PPH. The oxytocin should be there to combat with the fits. The magnesium sulfate should be there, and the antibiotics to reduce the infective mortality of the patients and the morbidity as well. We have to improve the blood bank systems and rapid donor mobilization to combat with the major obstetric hemorrhage. And we have to conduct quality quarterly emergency drills to combat with the PPH, eclampsia, and the sepsis. The referral and transport system should be improved. We have to have functional ambulance system with emergency contacts displayed, clear referral pathways from community to primary health care to district hospital and then to the tertiary referral care. That will reduce the delay from referral to the arrival at the tertiary referral care, and that will improve the patient outcome. And the high-risk patients should be treated by the multidisciplinary team. Then we have to expand the skilled workforce. Particularly, we have to deploy trained midwives and skilled birth attendants to the rural areas. We have to strengthen our THQs, DHQ hospitals to provide multidisciplinary care, because now we got so much specialists are available. They are deployed in these areas, and they should provide proper services to they are already providing, but they can provide a better care to these the patients of the obstetrics and gynae. Then continuous training for doctors, nursing, and midwives on emergency need mother and neonatal services. Then strengthen preventive care. We have to increase the family planning access to reduce the unplanned pregnancy. Particularly, the healthy timing and spacing of pregnancy is very important. The limited family size is important, and so that the mother can maintain her health before the next pregnancy. Then early antenatal registration and more than 4 antenatal care visits during pregnancy, and the high-risk pregnancy tracking is very, very important. Then we have to improve the nutrition and anemia management during pregnancy, because an anemic patient that tolerates the blood loss very poorly compared to a woman who is having a normal hemoglobin level, and all the complications of pregnancy are more common in a patient who is anemic. So anemia should be corrected, and the nutritional status of the women should be improved. Then we have to implement MPDSR nationwide, and we have to report every maternal death, and we have to conduct regular review meetings and implement corrective actions to reduce the rising maternal mortality. And district level dashboards for monitoring should be made active. And then certain community and social actions should be done, like we have to delay the early marriages and first pregnancy up to the age of 18 years. We have to improve the girls' education and awareness on danger signs at school and college level. And for that matter, we have to engage the community leaders. We have to take help from the religious scholars, and the lady health workers could be of help to educate the people at their doorsteps. Then governance and financing actions like allocate dedicated maternal health budgets, monitor quarterly indicators like MMR, EMO, and EMO coverage, and stockouts of medicine. It should be available in ample amounts at all areas, and establish district maternal health task force for accountability. That were the actions which we can have, which can use to reduce the maternal mortality and morbidity. And example of that is what we did previously. Our government took action in collaboration with the JICA. What we did, it was an initiative of Government of Punjab and JICA. Project duration was December 2021 to November 2025. The key interventions were strengthening maternal and newborn healthcare services, and that focused on prevention, early identification, and response to maternal death. And the idea was capacity building of frontline health workforce using the global standards. That 3 districts were targeted in that program: the Multan district, the Vehari district, and the Khanewal. First step was capacity building and training, and before that, training manuals. We developed training manuals in both local language as well as English language. We did training of doctors and midwives here in the Nishtar, and then the doctors, midwives, LHVs, we trained them. We trained the basically master trainers, and then trickle down training was done to train the other people. And in that program, we educated and trained 249 lady health supervisors as instructors, and 1,107 lady health workers were trained in 3 target districts. We did multiple trainings and retraining as well as refresher courses for these LHVs, LHWs, and the MOs over there. And that courses were conducted regularly after every 4 months. And the master trainers from the Nishtar, they also visited the BHU to observe that these trained LHVs and LHSs, whether they are working properly or not. And new equipments were for delivery and ultrasound were also provided there by the JICA and the Government of Punjab. And main focus of the project was to ensure the safe delivery, handle any complications at the time of delivery, and the neonatal resuscitation was also part of their. And it improved the overall maternal death notification and review, and that enhanced the quality of care and referral systems, and that strengthened the facility, the local facilities, and the community response, and that supported the reduction of preventable maternal deaths. And I just mentioned this just because this type of activities in which we do the capacity building of the various facilities, and they are like monitored periodically, and then we do the reassessment and support to them that can reduce the maternal mortality as well as the infant mortality. And to coming to the end, I would like to share that every mother's life matters, and every loss is a call to do a better. And a safe birth is every woman's right, not a privilege. And saving mothers is not impossible; it is indispensable. And I thank you all for patient listening. Thank you very much.
Thank you, ma'am. Thank you, Professor Dr. Mifnaz Fakhwani. Now, I would like to invite our next speaker of today's webinar, Professor Dr. Mohammad Tayyab. Dr. Mohammad Tayyab is a Dean Professor and Head of Department of Obstetrics and Gynecology Department at Al-Alim Medical College and Gulab Devi Hospital, Lahore. His expertise in data-driven maternal, neonatal, and child health interventions across low and middle-income countries is highly recognizable globally. Professor Tayyab's distinguished career spans academic leadership as former principal of Amiruddin Medical College and Postgraduate Medical Institute, Lahore, ex-vice president of the Society of Obstetricians and Gynecologists of Pakistan, and council member of the College of Physicians and Surgeons, Pakistan. An award-winning educator and master trainer in health professionals education, he has received national and international recognitions, including the HEC's Best University Teacher Award and multiple fellowships such as FRCOG and FACOG. His broader impact is reflected in his pioneering work in infertility, his contributions to clinical excellence, and his long-standing commitment to advancing standards in women's health through capacity building, research, and policy advocacy. Sir, please.
Thank you very much. I'm very grateful to Punjab Healthcare Commission for giving me this opportunity to talk about a subject very close to my heart. And with due respect, since my previous two illustrious colleagues have spoken for 30 and 20 minutes respectively, I will take the liberty of going beyond, a little bit beyond my allotted 10. So 11. So maternal mortality in Pakistan and the role of family physicians. I think we are all aware that family physicians are the front line, the first line of defense, and they are so closely knit with the family structures all over the country that we rely very heavily on their input in terms of combined care and shared care for all population, including women's care. And first of all, to set the scene, I would say that let's look at the family physician's cardinal checklist. Now, some of the slides that I had made, and I'm going to skip them now because they have already been presented by Professor Menaz and some by Dr. Saqib. So I'll skip those. But I'll set the scene by saying that whenever a family physician encounters a family or a patient who's pregnant or in that sphere, they need to know the following a few things. How much of her social and medical history do I know? And obviously, these people are very aware of the whole family structure and actually the nuances of their social relationships, obviously, that they know the closest than anybody else would ever know. But obviously, knowing their social and medical history, and how much of her obstetrical history do I know? Because the obstetrical history in the past particularly raises red flags. Is she compliant in her current pregnancy? Very important, obviously, because most of our ladies, in terms of access to healthcare, sometimes they don't have even a say in that. And the significant other in the family is more important, like a mother-in-law or the husband. And therefore, family physician can really be very proactive in terms of ensuring healthcare for that lady. Is my facility enough to handle all types of anticipated complications if they're looking after that lady? And am I aligned with Punjab Healthcare Commission? Luckily, when Punjab Healthcare Commission came, it became one of basically the regulatory body would make sure that basic facility that the doctors are claiming to be provided to patients are actually available. And if not, if there is any shortcoming, when and where will I refer her? You just don't put her in a vehicle and send her away. And we need to store where that person is going and what's going to happen to her. We're all aware when the complaints come to Punjab Healthcare Commission, the little lacunae that arise from there include that somebody has been sent away and doesn't know where. And will I follow up and know her outcome? Crucially important. And that leads to the last one. How will I use my lessons learned for the next patients? That obviously once an event has happened, what's going to happen after that? Now, what about the doctor-patient ratio in Pakistan? And that is interesting because the World Health Organization uses the benchmark of 1 doctor per 1,000 people for basic primary care. But actual needs, although may vary, and some recommend 2.5, including nurses and midwives, about 1,000. But countries with high physician ratios, approximate data of 2020, it is just like, it's not that we can copy that, but it just shows what kind of data do we have available for the most advanced countries around the world. And if you look at Pakistan, the benchmark 2.5, high income countries 3.3. India's reported ratio recently surpassed 1 in 1,000, reaching 1 in 900 according to their reporting. And Pakistan's situation historically below WHO recommendation with figure like 1 doctor per 8,000. Now that is definitely alarming. Architect, please, sorry. So that is definitely alarming because basically what it means is that we need to recognize the constraints in which all our doctors are working, all our teams are working, human resource working in the hospital, but also the family physicians, what kind of workload they are seeing. We need to recognize that at least and find out ways and means of how we can overcome that. This has already been defined by MNCH, so I'll skip that, what is maternal death and the maternal mortality ratio and rate. But just to keep in mind the last thing, which is that a woman's lifetime risk of maternal death, and that we need to understand, that is a probability that a 15-year-old female will eventually die from a maternal cause, assuming current fertility and mortality rates remain unchanged through her life. This risk is approximately 250 times higher for women in sub-Saharan Africa. That is how serious it is. Now, I was just calculating that this webinar today will probably be over in 2 hours, 30 minutes. And during this time, 3 ladies in Pakistan will lose their life, probably from preventable causes, most likely. And the Sustainable Development Goals have already been talked about, the 17 goals. This is a goal that we are related with, good health and well-being, and already it's been talked about, so we'll move further. Now, the lifetime risk, which I already mentioned, if you look at that, global average is not explicitly stated because it varies worldwide. And in low countries, it is 66, but in high income countries, you can see how different that is. And the maternal mortality rate has already been, or ratio has already been discussed, but this is just to, I picked it up from UNFPA site actually last night. And that starts from South Sudan, which has got the highest, and Pakistan is not in the first 12, and then Pakistan is not in the next 14 and next 10. But if you look at Pakistan, it's 154. But definitely, as already mentioned, we are far away from the goal to be achieved, which is 70. So a lot of work still needs to be done. Causes of maternal mortality, I think, has been highlighted very well, and that has obviously. That has not changed. This figure from WHO kind of more or less has been the same over the last 25 years. And also we need to keep in mind, whenever we look at resource, whenever we look at constraints, we have to keep in mind Pakistan is now the 5th most populous country in the world. And if you look at Pakistan and Indonesia, maybe Pakistan will overtake Indonesia in the next decade or so. And general list of large countries by density, that's another thing we need to keep in mind. Anybody who has visited Dhaka, it's very difficult to walk on the streets even because there is so much density of people. And you look at India and Pakistan density is lesser than India, although India is a huge country. But still we have to keep that in mind as well in terms of population dynamics when they present to doctors. And this population density, just to keep things in context, I picked this up. This is also from UNFPA side, and I picked it up. And there are the countries of more density, but obviously, in large, these are all countries in which most of them, except for Bangladesh, are not in large countries. They are small countries, so they have done well in other things. Now, 3 delays, we all know that, and this is just basically when we talk about the GPs and what they can do, we need to keep in mind that this is a very old concept, although well established. And we know that, and this, whenever a complaint comes to whenever a complaint comes to, Healthcare Commission, we know that where the delay has been taken place. Has it been taken, has that delay happened at decision stage? Has it happened at transport stage? Has it happened at arrival in hospital? And all of these contribute to maternal mortality. And I think the first one, the first part of this, the first delay in which decision, I think family physicians have got a huge role to play there, if they are really involved with the family in terms of decision making. This has already been presented. Actually, I compared this urban-rural divide from the last 25 years, and there's only 1 or 2% difference. And that was interesting because if you look at the rural population, percentage rural population from 1960, it has definitely come down in a very kind of straight kind of graph. But still, this rural divide is pretty high, as you can see, 60%. This has already been shown very well by Dr. Saqib, and I won't go into details of dynamics of that. But breakdown by division, just for our knowledge, there are now 10 divisions, 41 districts in Punjab in total. UNFPA Pakistan overview, I won't go into detail, but a lot of that has been already presented. I think Rubina is also going to cover a bit of that. Traditional culture of birthing, and we know what happens. Traditional birth attendants is not a problem. We need to train our traditional birth attendants because of this large rural population, and that is again where GPs have got a huge role to play because they are at the front line there. But lack of awareness among people and poor access to MOC. And I think this is something that Punjab Healthcare Commission really tries hard at enforcing what is basic emergency obstetric care, which is parenteral medications, normal delivery, manual removal of placenta, forceps or ventouse delivery, and basic neonatal resuscitation. And also, if you add cesarean section, blood transfusion services, and anesthesia, this is the second. I think any of us who has come to Healthcare Commission for advice on cases would see that a lot of complaints come from the second segment here, and we need to be aware that that is available or not. Now, what are the basic skills for family physicians? I think it's most important thing is good to know your patient's pre-pregnancy. We know, I was saying the other day, the diabetes in Pakistan, 1 in 5 Pakistani is now either pre-diabetic or diabetic. Diabetes, Pakistan is the highest country in the world with diabetes incidence. And every family, every other family will have diabetic, even juvenile diabetics there. So I sometimes see young girls for the very first time with a teenager with a blood sugar of 400. So it's very important to know your patient's pre-pregnancy, and family physicians are cardinally, crucially placed at that level where probably they know every member of the family. And it's so important that they know a comorbidity before the girl is, and some of these family physicians are actually attending weddings of their clients and families because they're so close to them socially. So, and once a patient is pregnant, you insist on seeing at least by 12 weeks of pregnancy with 1 dating ultrasound scan, and must get baseline labs done, must advise an anomaly scan at mid-pregnancy, 18 to 22 weeks, and identify high-risk pregnancy. Obviously, this follows from the very first line. Know your patient's pre-pregnancy. Probably if you have some idea of a past obstetrical history, you will be able to identify high-risk pregnancy. And then you make a plan for antenatal care suitable for her. There will be patients who will be in far-flung areas where their access is going to be poor. And there are patients within the larger cities in impoverished areas or slums or areas from where they will not be able to go for healthcare. And lastly, and crucially, know your limits. Obviously, it's very important for any physician to know what his limits is before he makes a referral. This is just a list of baseline labs, which I've had the opportunity of speaking to some family physician forums on this topic. And I've said, okay, please take this list down. Before you send them to the gynecologist, please get this baseline labs down, because you will be able to pick up a few things which will be of useful information by the time they have reached. High-risk pregnancy, obviously there are many ways to identify that, but anybody who is pregnant below 16 years, and yes, in Pakistan, we have girls who come to us married below 16, or patients who are above 40 years, patients with poor obstetric history, patients with a prolonged history of infertility, and you can imagine the pressure on the doctor for that pregnancy, patients who are obese, patients who are smokers, addicts and poor compliance, diabetes, hypertension, severe anemia, asthma, epilepsy, multiple pregnancy, and what Rubina would appreciate, domestic violence. Doctors, we have to pick up this. This is important. Main guidelines, obviously, these are already, I think, Minaz mentioned, leading causes of death: anemia, hypertension, hemorrhage, infection, and unsafe abortion. And I'll just take 30 seconds for these four. Basically, anemia, we know Pakistan, 70% women are anemic in pregnancy. It predisposes to half of all maternal deaths. And now we know that anemic patients will have more hemorrhage and likely to die more. So prophylactic iron, WHO recommendation is essential, and GPs are cardinally placed to make sure that as soon as the patient gets pregnant, preferably before, her hemoglobin level is normal. Which preparation to give, and we know that Cochrane database says any preparation is fine. And also we need to not forget that 1 out of every 15 Pakistani patients have thalassemia trait. Hypertension, I won't go into details of that, but basically is one of the leading causes of maternal mortality. So baseline labs must be sent, monitoring all the cases and referring well in time. Hemorrhage, well, in all the data that we have seen, postpartum hemorrhage leads, and previous history of hemorrhage is a huge red flag. Pregnancy, bleeding must be evaluated, and role of progesterone and so on. But it's very important that anybody with the red flag needs to be hospitalized and admitted and delivered in a hospital. Infection, as already mentioned, I think Minaz mentioned the second leading cause, septicemia. I think you mentioned, Saqib, second leading cause. So patient's history, place and mode of delivery, diagnosis, it's very important to take it seriously. People very quickly deteriorate with septicemia, and before they are picked up, sometimes they run into DIC, and you cannot not do much about that. About septic-induced abortion, we have to know the law of the country, and we have to be careful about that, and it's absolutely important that we look after that. And finally, so take-home messages. I feel that family physicians, though critically few in numbers, as we have seen the data from Pakistan and the number of people serving in the country, they are key partners in care of pregnant women and women's health. Many maternal mortalities witnessed in tertiary care hospitals, even those most are avoidable if they have come in time. We need to identify high-risk pregnancies, ensure compliance. And again, that is where family physicians can talk to husbands, talk to mother-in-laws to make sure the compliance is there. Close relationship with families, the greatest support asset in shared care, and timely diagnosis of problem and proper referral facility can actually save many lives. Thank you very much.
Thank you, Professor Dr. Tayyab. It was a very insightful presentation to emphasize the role of family physicians in saving the mothers' lives. Our next presenter is Professor Dr. Rubina Suhail. Dr. Rubina Suhail is currently serving as President-elect of the Society of Obstetricians and Gynecologists of Pakistan and as Professor of Gynecology and Obstetrics at Rashid Latif Medical College, Lahore. Her extensive expertise in maternal and newborn health closely aligns with the innovative strategies to reduce maternal mortality in Pakistan. She is widely recognized as a champion of sexual and reproductive health and rights. Having pioneered Kangaroo Mother Care in Pakistan and founded the Mahfouz Ma initiative, her distinguished career includes leadership roles such as President of South Asian Federation of Obstetrics and Gynecology, Chair of FIGO Committee on Women Facing Crisis and Tangible Contributions to Global Reforms, earning her prestigious fellowships and awards from the Royal College of Obstetricians and Gynecologists and SAFOG. Her dedication to advancing healthcare is evident in her prolific publications, including in the Lancet and IJOG, and in her ongoing advocacy for women's health. Professor, please.
Thank you very much. It's really a great day today because we are talking about reduction of maternal and neonatal mortality. And that's my dream, I think. And if we are able to achieve that, that would be a great day for all of us. So thank you very much. There are two parts of my presentation. It is that I'm going to talk a little bit about the current situation of maternal mortality in Pakistan, which almost everybody has talked about. But I'll just focus on a couple of key areas to stay within time. And secondly, I'm going to talk about a couple of endeavors to reduce maternal mortality in Pakistan. Now, if you look at the Millennium Development Goals and the SDGs, we were able to reduce the maternal mortality, but the maternal mortality was not reduced as much as we were looking for. So When the SDG started, the aim was to reduce the maternal mortality to less than 70 by the year 2030. So if you look at Pakistan like that, we are very precariously placed because our maternal mortality is nowhere near the figure of 70. This is a very important burden of disease of Pakistan snapshot, which shows us that the topmost reason for premature death in Pakistan is maternal and neonatal, and that should be a lamha fikriya for all of us that what is happening. A very busy slide, but I would like you to focus only on Pakistan. Pakistan's population has doubled in 36 years. Fertility rate in Pakistan in 2025 is higher than what it was in 2024 and 2019. Contraceptive prevalence rate in Pakistan has been static for the last 25 years. The method of contraception which is preferred by the public is the traditional methods. And if you see the modern method being a little bit more than the traditional ones, it is because of the fact that we are counting condoms as modern method of contraception, which to me seems like a shame. Pakistan maternal mortality ratio, though less than before, but it is still 155, and we are looking at a figure of 70 in the next 5 years, a daunting task by any means. The skilled birth attendant in 2024 has actually come down to 68% coverage in 2024. This is the overall situation. 155 maternal deaths, maternal mortality. As we speak, one mother almost dying every minute. 9,800 plus maternal deaths in Pakistan. And if we go with the pace that we are going, there's going to take 122 years to reach some status that we are trying to reach. So the situation is actually very much serious than we think it is. Now, what are the factors contributing to maternal mortality? And I won't go into a lot of detail, but just example of Balochistan, if you look at the geographical disparities, limited healthcare access, only 21% of population has got universal health coverage, and a significant number of problems with the rural areas where women are giving birth at home. Education gap, rural-urban divide, the medical complications like postpartum hemorrhage, sepsis, and eclampsia are taking the lead for maternal death. Economic barriers that women are not able to afford the kind of care that they should be deserving, and inadequate healthcare spending on maternal health and neonatal health is also one of the challenges. So if you look at the rural versus urban challenges, in rural areas, we have got a higher incidence of home births, limited healthcare facilities, 62% women are uneducated, greater distance from the hospitals, and fewer skilled birth attendants. So my key insight is that the maternal mortality in rural areas is about 26% higher than the urban areas. So this is the area where we need to be focusing on. And this also highlights the urgent need to invest into the rural areas more than that. I'm not going to go into this, just to say that hemorrhage and hypertensive disorders are our biggest killers, and abortion is something which we have been ignoring and not talking about. I'm not going to talk about the 3 delays in detail, but just to showcase you one thing, and that thing is that with improving access to institutional births, our maternal mortality rate will come down. But just to say that even now, we have around 26% of births occurring at home, and this is where we need to focus our attention. That why is that happening? A little bit about induced abortions. Our induced abortion is about, in 2023, the rate of abortion complication is 12.9 per 1,000 women. But just to say that around 1 in 5 children is born with an unwanted pregnancy, and 50% of them, the unwanted pregnancies are going to go through an unsafe abortion. And that is something which we need to be thinking about. So why is this unsafe abortion happening? It is because of lack of effective contraception, lack of provision of safe abortion services, and lack of timely post-abortion care. So these are 3 most important factors, and I seriously recommend that abortion is something we should put some weight over there. So every day in Pakistan, 675 newborns and 27 mothers are dying, and WHO is calling for urgent action. And not only WHO, we are also calling for urgent action. This is our current maternal mortality rate, 154. Basic and comprehensive EMC, I'm not going to talk about. The EM has already focused on it, but just one thing. And this is something which I learned when I was working with Barbara Kos for FIGO Save the Mothers project. And they actually taught us that 5 health facilities providing EMOC per 5 lakh population. So out of these, 4 should be basic emergency obstetrical care facilities and 1 comprehensive, and that is how we can divide our population and our resources to see whether effective care is available. Services should be available 24/7, and there should be equitable distribution of facilities and services, and that was my lesson learned. Now I'm coming to the endeavors of reducing maternal mortality in Pakistan. I have actually tried to focus on those endeavors of which I have been a part of. So just to share with you that what did we do, what were our lessons, and were we successful or did we fail? First, I'll try to talk about what the government of Punjab is actually doing. So just to reiterate the fact that according to the Pakistan Demographic and Health Survey of 2018, 74 births are institutional deliveries in Punjab, which I think is really, really something to be appreciated. In addition to that, the government has made sure that misoprostol is included in the essential drug list. They are working on the referral systems, and they are also working on the 3 delays. The 3 delays are basically the development of the LHW network, which is now in a little bit of a jeopardy. So I don't know what's going to happen to that. Provision of rural ambulance service, it is called 1036. The 3rd delay, they put in the intervention of patient triage, and 4th delay is now being called the MPDSR, and the government is working on the MPDSR. The only problem with all these interventions is that all these interventions are sporadic. By that I mean that all these interventions are not available in all the provinces, number one. Number two, in all the districts or all the healthcare facilities. So some facilities have these facilities available, others don't. So that is why we need to be looking at. Now, the strategies to reduce maternal mortality, everybody knows about them. Skilled birth attendant, emergency obstetrical care, and to work on the 3 delay model. But what is actually happening? If you look at it, what has the government done for the 1st delay? Provision of community midwives, creating awareness, and trying to subsidize the treatment by the health card. For the 2nd delay, ambulance service, but the government needs to work on waiting houses next to the healthcare facilities for women who are high risk and not able to reach the facility in time, or where the hospitals are overburdened. So these kind of houses can be of some help. For delay in care, the government has also instituted already the triage system, but we have to ensure that in all the healthcare facilities where maternal health is available, equipment and training has to be of a certain minimum level, and we also have to make sure that it is available 24/7. MPDSR, the government is working, but the important point in this is that 35% reduction in maternal and perinatal mortality can take place if we focus on this, if we focus on the cycle of what is happening and what could have been done to improve the situation. So these are the endeavors to reduce the maternal mortality in Pakistan, about which I'm going to show you maybe 1 or 2 slides each. So let's go to the first one, which was my introduction actually into maternal health, which was in 1997 with FIGO Save the Mothers project. And Dr. Tayyab sitting here was also part of that project, where we tried to establish a network of emergency obstetrical care services. We focused on local resources. It was a low-cost project. Britain was our partner. We tried to create awareness and influence attitudes, and we published as well. And the project actually was extended, and we went till 2002. When we went with this project to the government of Punjab and said that this needs to be replicated in whole of Punjab, the government was not interested. And that is why the lessons learned from this project were not actually implemented throughout Punjab. If in 2002 we would have been able to implement these lessons, I think that we would not have been sitting here and discussing what we are discussing today. So our lessons were that local capacity is the key to reducing maternal mortality. We have to focus on emergency obstetrical care. We have to address the root cause like PPH, eclampsia, and unsafe abortion. We have to overcome 3 delays, and political will matters. And this is a picture of Professor Chris Hudson, who was a very, very integral part of our project and who's no more. Then we did a PPIUD project, and you would be wondering, why are we talking about PPIUD in maternal mortality? Because birth spacing can reduce maternal mortality. This project we did in 2015, and with this project we learned that PPIUD can play a significant role. So we developed a contraceptive plan for our own unit in Services Hospital. And the plan was that we would counsel the patient for contraception, and mostly focusing on long-acting contraception at 28 and 32 weeks of pregnancy, help them make a decision, stamp their antenatal card with the decision, and when they would come in labor, we would confirm and take consent for the method and provide service at the time of delivery. Then I would like to talk about, this is actually Mehfooz Ma, is just nothing, it's a name, because we want to talk about keeping our mothers safe. And in this project, actually, we have worked on PPH prevention and management, and we have worked on anemia eradication. And the upcoming plan is working on eclampsia and integrated delivery care. This actually started by a master training workshop which we conducted in Sri Lanka with the help of an American doctor whose picture is also shown over here. And we trained 22 participants from Pakistan for the PPH bundle approach, which we followed later on. With this project, we have been able to, we started in 2022 and this is currently 2025. So we have conducted 48 workshops. And if you see, we have gone almost to all the provinces of Pakistan, somewhere more, somewhere less, but we continue to work on it. The biggest challenge with this thing is we have done the trainings, we have done the interventions, but our biggest challenge is still the data. The data has started coming in a little bit, but it is very sketchy, very difficult to get clean data. And this is the place where we are looking for support from developmental partners, and maybe the Healthcare Commission can be our partner to help us. So the basic strategy in this was that we would prevent anemia. We would diagnose blood loss by visual assessment of blood loss. We would declare PPH because we realized that in most of the cases of PPH, PPH is not diagnosed when a blood loss of 500 ml has happened. PPH is diagnosed when the patient goes into shock. So we have tried to change the attitude and we have tried to train, and then management by the clinical bundle approach. The interventions are primary and refractory and very simple interventions which midwives can also learn. And it is to do with anti-shock garment and intrauterine balloon tamponade. This is just to show you what it is all about. And also to show you that there is a non-clinical component as well, and which is actually very important: leadership, data, respectful maternity care, facility readiness, teamwork, and network integration. And network integration, I think, is the key message for Healthcare Commission, because while Dr. Mehnaz was talking, I was thinking that we need to make sure that the tertiary care facilities, all the facilities who are draining into the tertiary care facilities actually should be made the responsibility of that particular facility, so that they're able to gauge where are the maternal mortalities, where are the significant morbidities of the mother coming from, where are they being referred, in which condition are they being referred, and if the tertiary care hospital can take care of those facilities, go back, train the healthcare providers over there, and then become a team with them. That is called network integration. And if we are able to integrate the network, then maybe 5 institutes in Lahore can have their own areas. They can all look at the maternal mortality and improve the mother's health, because unless we divide the work, it is not going to happen. And that is what we need to be thinking of. This is just a picture to show you what we have been doing, but there is an important thing over here. And there are two important things other over here. One is that we work with WHO to develop the clinical guidance for the PPH bundled approach. And the second thing is that we were able to develop, with the help of a lady doctor from Salport, the PPH anti-shock garment. And this anti-shock garment was previously not available in Pakistan, but now we had it custom made. And I advise that every facility in Pakistan should have at least 2 anti-shock garments, so that the patient referral can be made easy. And the important role that this anti-shock garment can do is you just wrap the patient in the garment and the bleeding stops. So if a patient is being referred or if she's bleeding heavily, we don't have a healthcare provider, we don't know what to do, this is your solution and this is what you should be thinking of. I'm coming to the end of my presentation, but just a couple of slides more. This is the anemia eradication initiative, again started in SIMS and continued with the MEPUSMA. And I would just like to point out that we were a part of the Woman One trial. And when the Woman One trial ended, we thought that we need to tackle anemia. And in our unit, what we started to do was that we developed a 3-pronged campaign. One point was that we would deworm every patient in pregnancy who were our book patients, do hemoglobin estimation, which we were doing in the first trimester as well, but at 28 weeks of pregnancy. And if the hemoglobin of the patient was less than 11, we would inject carboxymaltose according to the Genzoni's formula, so that every patient presenting to us in labor would come with a minimum hemoglobin of 11. And then active management of 3rd stage of labor was encouraged. What happened with this was, we started doing it and we did not do any data collection. But what happened as a result was that when Women Trial 2 was started, Women Trial 2 actually was to do with patients who were already suffering from anemia. And we suddenly realized in our book patients, there was no anemia. So that is why in MEFUSMA, we started working on this. the same thing. And we have done, we are just in the beginning, and we have done this anemia eradication initiative in 4 cities. So we go to the antenatal clinic, and these 4 hospitals we covered, and we found out, so we checked their hemoglobin. Any patients who were less than 11 hemoglobin, we gave them carboxymaltose according to their requirement. But we found out something grave, that in Firozwala, we found out that there were 80% patients with moderate anemia. In Hyderabad, we found out 25% patients with severe anemia. In Kasur, 55% patients with moderate anemia. It needs to be thought about. This is a government intervention which I especially admire, and I wanted to talk about it. This was the charm project of government of Pakistan, and it was the Chief Minister's initiative. Not of this government, but of the previous government, probably. Maybe of the previous to previous government, I don't know which one. But there was something very important things were done in it. The mobile, so basically the concept was emergency critical care, but mobile messages were used and the community midwives were used. So when a woman would register with the community midwife, they would inform the main core office that this woman is pregnant and is registered with us. So then the government would do the rest of the things, but the additional thing that they did was that they would send mobile messages. And these are the 10 mobile messages which were sent to the woman and her family, so that they would come for antenatal, they would high-risk pregnancy identification was done, delivery in institution, early onset of breastfeeding, contraception. So these kind of messages were there. And I think that it was an excellent project, and this could have been actually replicated in the whole of the country as well. So my lessons are the same as that for everyone. The same about skilled birth attendant, access to emergency care, and the 3 days method. But I think there are a couple of important messages which are other than that as well, which are that we need to include the public and the private sector. We have to make sure that we form uniform services throughout the country. We cannot do it sporadically anymore if we want to reach the figure of 70. And the second is that evidence-based interventions should be taken care of and implemented. Third is promoting 100% institutional delivery should be our target. So basically, the integrated approach for maternal and neonatal health, to me, is the way forward. And I will just end by saying that women are dying. Women are not dying because of diseases we cannot treat. Actually, they are dying because societies have yet to make the decision that their lives are worth saving. And these are the words of Mahmood Fatala, who was the president of FIGO. And I think anybody who's working in maternal health, he's the godfather for maternal health for us. Thank you very much.
Thank you, Dr. Rubina, for a very comprehensive presentation. And with this, we end our maternal health, maternal mortality session. We had 3 presentations in this respect. And with this, we now begin our next session, which is on neonatal or newborn health and discussing neonatal mortality. With this, I introduce our next speaker, Professor Dr. Irfan Wahid. Dr. Irfan Wahid is a distinguished professor of neonatology and former chairman of the Department of Neonatology at the University of Child Health Sciences, the Children's Hospital, Lahore. With over 2 decades of leadership, Professor Dr. Wahid's notable contribution has provided us pioneering leadership in specialized neonatology training programs, founding critical courses in neonatal resuscitation and mechanical ventilation, and mentoring the largest cohort of neonatologists in the country. He has served as a member of technical working group on newborn care of the Punjab government and the Ministry of National Health Services. His research input includes numerous publications and authorship of 9 books, driven by a commitment to capacity building and systemic improvement. His work has significantly modernized neonatal healthcare services, setting national benchmarks in both practice and medical education. So with this, I invite Professor Dr. Irfan Wahid.
Thank you. Thank you very much, Punjab Healthcare Commission. And I don't know about whom Dr. Kumar was talking. Certainly not. I'm going to talk about the state of newborn health in Pakistan and what we have done so far and what needs to be done. Pakistan, we know that the population of Pakistan has now exceeded 25 crore. But this figure is not important. Important is the annual number of births in Pakistan is 6.8 million. Or 6 lakh bache. They are born in 1 year. And further important is that out of them, 2,59,000.259 million babies, they die in 1 year, leading to a neonatal mortality rate of 38 per thousand live births. I'm very grateful to South Sudan because previously Pakistan was at 39 at par with South Sudan, and we were #1 in the world as regard neonatal mortality rate. But now, because South Sudan has gone up, we are at #2. 65% of under 5 deaths are constituted by neonatal mortality. And unless we reduce neonatal mortality, under 5 mortality or infant mortality is not going to come down. This has been seen over the last so many years. About 70% of the deliveries they are conducted in institution, and about the same percent by skilled birth attendant. The important point is not that 70% are conducted in institutions and by skilled. Important is that 30% are conducted outside institutions by unskilled people, which is a big number. It means there are more than 2 million babies are born outside safe places. And those are the areas where the problems arise. 3 major causes of newborn deaths in Pakistan are the same as everywhere else. Number 1 is prematurity, about 40%. On the second are infections, and number 3 is intrapartum related problems, in other words, asphyxia. If we see that 86% of the deaths, means 259,000 in a year, out of them 86% die within first 7 days of life. The rest of the 14% of the babies, they die in the rest of 21 days. And out of first 86%, 33% of them, they die on day 1. And mostly these babies are those which are of asphyxia, a birth-related problem. I have prepared this slide to show the extent of improvement in under 5 infant and neonatal mortality rate of last 50 years. If you see that under 5 mortality has improved quite a lot, from 166 to 50. The reason is primarily because improvement in treatment of diarrhea and pneumonias. Infant mortality, which is less than 1 year, has also improved, and you can see the slope. But neonatal mortality is almost the same, which was about 50 years back. There is no improvement, no significant improvement. We all know that Pakistan is a signatory to Sustainable Development Goals, goal number 3.2, according to which we have to reduce our neonatal mortality by 12 per 1,000 live births by the year 2030. Or according to every newborn action plan, it has to be reduced by 10 per 1,000 by year 2035. WHF gave us 6 lines of action to promote agenda for 2030 to meet SDGs. I'm not going to go into the detail of everyone. Similarly, ENAP gave us 12 points agenda to act on, and this was signed in 2014. For last 10 years, we have been trying to meet this and follow these things. And what is the result? If you can see, the annual rate of reduction of Pakistan previously was 1.8%, and now it is 1.6%. We need 5 times this rate to meet SDGs. If we cannot meet even now, I don't know, we are at 1.6. How are we going to achieve about 10 to 13%? And this is the main point of, I think, whole presentation, that so far, whatever the action has been taken by anyone, they have not been able to make any impact. Rather, we have worsened. I have also put up this slide just to show you the comparison between annual rate of reduction between Pakistan and our neighboring countries. Shamefully, the Pakistan is the worst, even worse than Afghanistan. What are the major challenges that we face? Number 1, there is disproportionate load of patients versus health facility. This is an actual photograph that I myself took 7 babies on one cot. There are no specialized maternity and newborn hospitals. There are only few dedicated neonatology units. There is relative lack of resources, both human in the form of nurses, doctors, and support staff, which has also been highlighted by Dr. Saqib Saab. And further, there is maldistribution of resources. Higher number of more resources are spent on tertiary hospitals, urban areas, and which are mostly curative rather than preventive. And there is no level of healthcare facility where patient just walks in. What I mean to say is that level 3 are basically meant for a referral system, but now any patient can walk in at any time and they will demand same care which will be required for a serious illness. There is no check on this. So what have been the efforts in reducing NMR in Pakistan in last years? What Ministry of National Health Services, Neonatology Group of Pakistan Pediatric Association, WHO or UNICEF have done? National Newborn Survival Strategy has been launched. Universal Health Coverage Benefit Package has been launched. Every newborn action plan strategies they have been launched. Essential newborn care packages have been started. Strengthening of data systems in the form of DHS, DHIS2 and MPDSR, they have been initiated. So a small and sick newborn 3-day training course that was started. Antenatal corticosteroid guidelines have been established and published. KMC guidelines and IKMC lines they have published. Breastfeeding policies have been established now. And neonatal resuscitation manual and training has been initiated. In addition to these have been initiated in the last couple of years. In addition to these, what the literature says that we need some innovations in our approach because previous approaches they have not worked. We have to reach the community. Community has so far been the most neglected part of our whole healthcare system. That is introducing and using lady health worker or community health workers, things like that. Oxygen and pulse oximetry systems are very simple. We have about 16% of preterm births, which can be managed very easily if we have these instruments with us. Similarly, introduction of positive airway pressure and respiratory support. I'm stressing this because the largest cohort of mortality is from preterms. Similarly, jaundice and hypoglycemia, point of care tools, they need to be introduced. Currently, there is no defined, there is basically referral system, but which is not being followed. And moreover, there is no neonatal transport system in Pakistan. Even these rescue 1122, they do not transport newborns, and they even do not know how to resuscitate a newborn. Quality improvement initiatives in newborn units, they need to be introduced. Data and digital health, that needs to be followed, especially teleneonatology for remote areas and case discussions, GIS mapping, they need to be introduced. Public-private partnership to upgrade neonatal services is a need of the hour. All these are termed as innovative ideas for improvement in newborn mortality in Pakistan. I'm going to refer this to an article in Lancet that was published in 2014, which outlined priority areas for Pakistan. Where should we focus? We know, and I know that Dr. Professor Rubina has also mentioned it, and I second her. We need to focus on community and rural areas more than the cities and urban areas. Most of the problems that arise and those even arrive at the tertiary hospital are from community and rural area. What should we focus? Again, the three most common causes of mortality of newborn, that is preterms, asphyxia, and infection. All three are preventable. When to focus? Highest number of deaths is around birth. So best time to intervene is around birth to save maximum life. And as I already mentioned, preterm and small babies, because they made a very big chunk. Pakistan is one amongst the countries with one of the highest preterm and small for gestational age baby. So we need to focus them. Other strategies that might help is to focus on high impact and low cost interventions first, and then go on to the other intervention. We have to adapt locally rather than following the West in everything. We need to adapt locally. Our problems are different than the Western problem. And we must consider baby and mother as a dyad, not individually. Mother is not separate. We cannot save the baby without taking care of the mother. And we have to build systems around these strategies. What we recommend the priority areas for Pakistan for next 3 years. Number one, we need to ensure neonatal resuscitation certified staff plus basic ENC at delivery point where functional equipment is there. I know this is one of the indicators in Healthcare Commission MSTS, but I also know that this is not being followed whenever scrutiny is done of any healthcare facility. We need to improve breastfeeding practices. Currently, only 20% of the babies they start breastfeeding in the first hour of their life. We have to establish and expand KMC, kangaroo mother care, which has shown to improve child survival, newborn survival. We need to scale pulse oximetry and oxygen system and standardize bubble CPAP across district. We have to establish neonatal transport system. In 2021, that year, I received in Children's Hospital 1,700 dead babies in our emergency. 1,700. The previous year it was 1,500, and the previous year it was 100 or so less. So most of the babies, when they are born in the periphery, what a die or whosoever is delivering, they would just wrap up the baby and they will send it to tertiary hospital for care. And most of the babies will die because of hypothermia. There is no neonatal transport system at all in Pakistan. It is totally different from a transport system of adults, because neonatal teams, they have to transfer the babies. Neonatal transport needs a very highly trained neonatal people. We need to institutionalize MPDSR in quality improvement collaborative and develop public-private partnership. Very essential to achieve the goals is political commitment, involvement of private sector, community engagement, data collection and research. And I'm happy that Punjab Healthcare Commission and Dr. Huma has given thought for this data collection and research. But most important is accountability and sustainability. Without these two, nothing will work, and it has not worked so far. This is my last slide, which shows that out of 195 countries, 67 improved their under 5 mortality rates by 2/3, and out of them, 28 were low middle income countries. So it means it is possible for a low middle income country to achieve these targets. And we just have to make best use of whatever is available with us. In summary, situation of neonatal mortality rate in Pakistan needs serious attention. Not only neonate, but mother and baby must be cared for as a unit. And we need cooperation and of obstetrician colleagues in this. So if mother and baby are dyad, so a neonatologist and an obstetrician should also be made like a dyad. We need to focus on low cost, high impact intervention, and attention should be paid on priority areas like neonatal resuscitation, breastfeeding, KMC, and transport. We need to introduce community innovations, which have been totally, I would say, neglected so far. The community, and I have requested Dr. Kuratalan from UNICEF also to work on community, and she is up to it. Then accountability and sustainability is mandatory to achieve the goal. And without political commitment, we are not going to achieve any of this. Thank you very much.
Thanks, Professor, for very thought-provoking presentation and really bringing us this emergency call for attending to NMR and giving us this inspiration that so many people have done it. And if Pakistan is willing to do it, is determined to do it, we can all together can also reduce our neonatal mortality rate by integrated approach. With this, our list of speakers has ended. We were to have in our schedule a talk on child survival by Professor Dr. Harun Hamid, but he, because of his urgent call to a meeting, was not able to join us today. So we would be having similar activities in future, and we ask our audience to please stay tuned. And with this, if you see on your screen, you see our flyer, and in the lower left section of our flyer, you see that there is a call for abstract. So we must be thinking that there are no scientific presentations of out of the peer-reviewed abstracts taking place in today's session. So what is this call for abstract for? So this is for our upcoming events, and hopefully these events would be individually planned. Sessions on maternal health and mortality, then neonatal health and newborn health and neonatal mortality, and then child health, child survival. So you are all invited to participate in this call for abstract. The last date is 31st December, and you can share the challenges you face, the data analysis you have done for your institutions, and any interventions which you have planned and the outcome of those interventions. So this would become a platform for peer learning and collaboration. So today's event is in fact the first in this direction. And we hope for active participation from our hospitals in Punjab in this regard. Your mentors are there to guide you around. And with this, I would like to invite Professor Dr. Mahmood Shaukat for his concluding remarks on today's session, please.
Thank you very much. I wouldn't call what I'm going to talk about as concluding remarks, but because you can't really conclude anything on such an important topic. I'm just going to point out a few things, because I think today's activity has generated the real questions that we need to answer. We haven't really even asked ourselves the real questions earlier. What we talked about is the grammar. What we talked about are the principles of reduction of these immense issues that we have before us, like the neonatal mortality, maternal mortality, high gestation, high growth rate, explosive population growth. So what are the questions which are going to provide an answer for these problems? The questions, I think, for the first time we have identified today. The first thing is that we need to rethink. There is one thing for sure: Pakistan is a graveyard of signed MOUs and treaties. We just believe in signing them and then forgetting about them. The third thing is that the real first step in improvement, thinking about improvement, is a critical review of what have we done. So what has this grammar so far achieved? We all know how do you reduce the mortality. We all know the causes of mortality. We all know anemia is prevalent. We all know we are diabetics. But whatever interventions have we done, how successful have those interventions been? That would set the stage for future any intervention. Why do I say that? Let's say for one moment that we're talking of maternal mortality. And we're talking about mortality that is registered in the hospitals, in the healthcare establishments. What about the 42-day rule? How many deaths did we have 30 days down the road or 42 days down the road? Hardly any. So we're just recording the mortality around immediately the birth process. So that is something that came very, very strikingly in this discussion. The second thing is that here we're practically talking about low-income group countries, middle-income group countries, and high-income group. What actually happens? What comes with this bundle of low-income group? What comes with the bundle is very predictable, poor education. You have a very bad professional attitude. You have a very poorly regulated society, and with all the consequences of no control over things. You have no conviction. You have bad nutrition. You have very high load of communicable diseases. So do we go to the middle income or high income group countries? Or I'm very happy what you suggested, the 28 countries, how did they do it? The answer is not reiterating the grammar. The answer is to find the right and appropriate intervention steps. And that would be totally different, because I firmly believe that nothing works as a copy, cut, and paste. You have to look into your own situations. You have to be creative. And the second thing is that when we talk of neonatal mortality and maternal death, these are crude indicators of the prevailing conditions. Many of these children would be stunted in growth. Many of these children would produce very low academic performance. Most of our society never comes out with a creative idea. So these are consequences which are of long term of a poor management in these years. Now, the third thing, which is very striking, is that we had a lot of interventions by the first speaker, Professor Manaz. I'm very grateful to her that she brought this up. But as a matter of fact, nothing changed. If things didn't change in Nishta, so how are we going to be able to change anything in the periphery? The pattern of deaths remained the same, if at all. It may not be statistically significant, but the numbers were higher. The types of death didn't change, the numbers became higher. So what is the question that needs to be asked? Whatever have we done, has it given us the results? So the real critical review would tell us where we failed, where we need to modify, where we need to do something innovative. Now, I have one very simple thing to ask. We need to integrate our services. Why can't a polio worker also ask, is there a pregnant woman in the house? Why can't that lady go and check her hemoglobin? Why can't we have, like we have so many mobile hospitals and we have so many things, and we have 385 primary healthcare facilities in Lahore under the local government. They're not working. I had this survey done for a process where we were trying to develop a referral system, and most of them are not. Why can't we make them maternity and child surveillance centers, attach them to the tertiary teaching care hospitals, and put there just ultrasound machines and just have an antenatal assessment and anomaly scan and do the hemoglobin of the woman. When you want them to come to the hospitals, they will not, because we don't provide them facilities for coming to the hospital. Then they have to line up in the hospital. They have to sit there for hours. They can't do it. We have to look at our conditions. Our conditions, both economic and the general prevailing law and order situation, and the ability of a woman to leave her home with 3 more children at home, and the responsibility for cooking and doing so many other things. It's not easy for them to go to the tertiary care hospital. And then the tertiary care hospitals are not safe either, by your own record, and they haven't improved. So how do we plan to improve the outcome in the tertiary care hospitals? I think this, I'm very grateful to Irfan, particularly for 2-3 things that he said. Number one is that we have to innovate. The name of the game is innovation. The innovation comes when people look at the data critically, come out with the problem, ask questions, not look for already established answers. We have to ask questions. Why are we not succeeding, although we are following the same grammar? Why those 28 countries succeeded and the 46 didn't? So that is where the answer would lie, because they are similar to us. They're not like Europe or America, they're similar to us. And then we need to really make a framework whereby we can tackle this one issue in a much bigger way. And at the moment, the only crude variable is death of the woman. And we don't even know how many of them would have a late death, 2 weeks or 3 weeks or 1 month after delivery. So I think we need to really, this is a very good exercise, but this needs much more input, much more review of the data, much more looking into the reasons why we failed so far. Then we'll be able to phrase the proper questions. Then we need to have a brainstorming session where we find answers which are local, which are indigenous, which we make according to our local reality-based conditions. And then possibly we have a possibility of going forward. Otherwise, I think it'll just be the same story year after year. And what worries me is that with the explosive increase in population, we may not actually go back. This maternal mortality and neonatal mortality may not jump a little more, because that is the real thing, that our new facilities are not in pace with the explosive increase in population. So I think the real danger is that if we can stay at this number, what to talk of going down to 30 or 19 or 20, that's impossible. But if first priority would be to stay to this number, look after what more population is coming to you, and then make a plan where you can really intervene. Otherwise, this will remain the same, and we will continue to talk about the same things. I think we need to move away from grammar. This grammar has given us a sentence which hasn't answered our problem. We need to phrase a new sentence. The grammar always remains the same. The principles always remain the same. It's the implementation, it's the logistics that determines the outcome, that determines the result. And I think that is what we really need to work on. So in no way is this a concluding remark, but I'm very happy that this activity would generate the real questions that we all need to ask ourselves, work on them, and come out with doable, with tangible solutions that can actually be implemented at the community level. Thank you.
Thank you, sir. With this, I would like our audience, which we have around 200 people, 150 to 200 people online viewing us right at this moment. And I would like to ask them to please go in the chat box and see the Google form, feedback form, and fill it up so that we can have your feedback for planning the next webinars. And we can also know that which audience was listening to us or interested in pursuing the goal of MNCH in the province. So please do give your feedback on the Google form in the chat box. Thank you. With this, I would like to ask if CEO sir, you'd like to add anything or end with the vote of thanks. I would like to ask Dr. Mushtaq Ahmad, Director, Clinical Governance and Organization Standards, Punjab Healthcare Commission, to please say a word of thanks to our speakers and guests.
Thank you very much, Dr. Abba. It's my profound privilege to thank all the speakers, and particularly Professor Sehat Sahulat, the renowned pediatric cardiac surgeon and leader in the healthcare system, and also being with us as a commissioner of the Punjab Healthcare Commission on the board. Thank you, sir. Thank you for your time. Or thank you, all the speakers. I think all of you who are present here and those who have joined on our link. They have been they have provided a very insightful talk for the professionals, for the managers, and for the leaders in the healthcare profession, and also for the policymakers. I think Dr. Rubina, Professor Tayyib Saab, or Professor Irfan Saab, they have always been forthcoming to support Healthcare Commission in the process of developing standards and guidelines and all that. All the documents which we've been preparing in consultation with the stakeholders. Sir, thank you very much. एक दो important चीजें जो point out हुई. Just I'll be happy to share with the speakers as well with the audience. कि इन सारी चीजों में regulator as a regulator Punjab Healthcare Commission दो तीन तरह की intervention कर रहा है in addition to developing and enforcing service delivery standards. हमने sir in our capacity as a regulator and as per our legal mandate, we have also proposed to the government to integrate the family physicians and the primary healthcare service provided in the private sector into the mainstream healthcare system, so that the first point of care is strengthened और वहाँ पे लोगों को अच्छी quality की care मिले, number one. और इसी proposal के साथ we have also proposed their capacity building, particularly in advanced pediatric life support and obstetric life support, to recognize high-risk pregnancies and to refer them at appropriate time. Also, इसके साथ-साथ जो भी हम advisories government को share करते रहते हैं in our capacity, उसमें health human resource से related, और particularly हमारा ये I think we are very convinced, or all of us are convinced, that it's not only the obstetricians and the senior level consultants who can help in controlling maternal mortality and infant mortality, it has to be addressed at the community level, and that can only be ensured through having adequate in number and adequate skill mix of the healthcare service providers, or particularly those which are involved at the primary healthcare level. Similarly, sir, इसी में हमने थोड़ा सा एक और गवर्नमेंट को प्रपोज किया हुआ है जी, to strengthen referral system so that the patients they are referred in time to the tertiary care, secondary care hospital in case they require specialized care, so that the three delays in the maternal mortality are addressed. Similarly, ये सारी चीजें सर we are improving our standards also continuously. Professor इरफान साहब के साथ neonatal resuscitation के ऊपर बात होती है. Professor Tayyib साहब, he's been advising us on the forum of technical advisory committee of the commission, and he's there for the second time, and we are lucky to have his inputs. Professor Rubina is continuously supporting us. और इसके साथ साथ I'll also thank the representative from Director General Health Services Office, Additional Director साहब, for being with us, और खास तौर पे डॉक्टर कुरत जिनके साथ हमारा यूनिसेफ के साथ इंटरेक्शन भी रहता है. But this is a shared mandate of all of us. एक बात जो कमीशन साहब ने, प्रोफेसर महमूद शौकत साहब ने कही कि we are graveyard of signed MOUs. इसके साथ साथ सर एक और इम्पॉर्टेंट चीज है कि we are champion in piloting the projects, but we don't integrate and incorporate the lessons learned into our policies. और of course जो सीओ साहब ने फरमाया कि first health policy, national health policy was formulated in 1990. उसके बाद second आई in mid-90s, late 90s rather. उसके बाद we don't have a formal health policy at the federal level, and of course at the provincial level, and we are just working on health vision and health strategies or things like that. So that basically this is the issue कि हमारी जो policies हैं, they are not consistent. Number one, they are definitely not based on data. Any data which is available again will not be very credible and authentic, and we need to also look into that. Thank you very much. Thank you all those who have joined us on link. Or I think with the permission of the chair, CEO Saab or apna Commissioner Saab, we close our webinar, or as has been informed in this program, we will have a brief group discussion just to conclude what is the way forward, or kya recommendations hame aayi, or what is to be done by which level of partnership. Thank you very much. Thank you, CEO Saab, for providing us leadership, or Mahmood Shaukat Saab for your presence. Thank you. Thank you. Thank you, ICT team, for providing the support also. Thank you.
On my own behalf and on behalf of Punjab Healthcare Commission and on behalf of the Board of Commissioners of Punjab Healthcare Commission, I thank all the distinguished guests, speakers, and all persons who joined us for taking out your time and for being with us and sharing your views and your suggestions. And as rightly said, that it's time to action and move ahead from cliches, and I think the time to act on evidence-based data. And from our side, it is not the end of the story, and we will continue making our efforts and our contribution in this very important field. And as our head of MNCH, Dr. Huma, has just said, we will be inviting your technical papers and your abstracts, and soon, which inshallah soon again be meeting to discuss and to make more efforts and what would be the action to address this issue. I again thank you very much, all of you, especially Dr. Kuratadan, for being here, and rep of the office. Thank you very much for the, thank you very much. Sure. We're done.